Testicles seem to have a much longer survival time than what the literature supported or what the literature stated.
That's right. We're survivors, baby.
And so I would have patients come in, or I would see reports of patients that had had testicular torsion for days and survived.
That's none other than Dr. Larry Mellick of procedure video fame. And we haven't spoken with Larry in about 5 years. The last time was back in August 2018, talking about testicular torsion. We are revisiting that topic today with some updates, as well as some reminders of areas that Larry thinks we are continuing to think about wrongly.
As I dug into the literature, I found out that there was just article after article that reported testicle torsions that survived for far, far longer than 6 hours. And in the meantime, I've had at least 4 patients now, one as of just like 2 weeks ago, that have had torsions for at least 70 hours who have had testicular survival. This has become a mission for me because I just think that the 6-hour time frame that is so commonly taught is dangerous. And what happens is you have a patient that presents with 24 hours of testicular pain, and they're in your waiting room. The natural response that I frequently hear is, that testicle's dead. There's no big rush to get this patient into a room. We'll get them in here when we can. I think it's important to get the word out there that you have to give every testicle a chance.
Damn right.
And that means getting them quickly evaluated, getting an ultrasound as fast as you can, documenting the presence or absence of blood flow, and then as quickly as possible, do an intervention. In other words, the lesson here is never give up on a testicle.
Amen to that. We may be down, but we're not out.
So why is it that some of these testicles, even with 4 or 5 hours of no flow time, are dead, and other torse testicles will survive for 24, 60, 70 hours out?
First of all, I don't think there's any testicle that dies in 5 or 6 hours. And I think the studies that say that there's like a 3% death rate within 6 hours, I think there's more to that story. I think it has to do with patients who weren't feeling any pain and arrived within that 6-hour time frame, and by the time they arrived, the testicle was dead or was just starting to hurt because of the inflammatory factors. We do know that the longer the testicle is torse, the greater number of turns or degrees of torsion will increase the chance of poor outcome. And then it's the thickness of the spermatic cord that I think makes the difference. The thickness of the spermatic cord changes the twist. In other words, they call it the helix. It's that twisted part. And that the helix of a very thin spermatic cord is very short. And so it's very effective at cutting off blood flow. On the other hand, a thick spermatic cord with a long helix actually allows some persistent blood flow that allows these testicles to survive for longer periods of time.
The bottom line I think that everyone should take away is that there isn't a time cutoff after which that testicle is non-viable. Like you said, every testicle deserves the opportunity for revascularization. And I think we hear it on both sides, Larry, both the patient who says, I've had pain for 24 hours, and so no one's really rushing to get the ultrasound. But then also when we find the torsion, one of the first questions we get asked by our consultants is, how long has it been? And sometimes we see things just slow down as soon as we say, well, it's been 8 hours, or it's been 10 hours, or they've had pain for the last day or so. And I think that's where we really have to push and say, I know they've had pain for a long time, but that duration doesn't necessarily tell us that that testicle is going to be non-viable. As long as we keep that in the back of our head, I think we can do the right thing for the patient. Larry, you published a systematic review of cases of testicular torsion. What did you find there in terms of the time of viability?
We found that 0 to 6 hours, there was a 97% survival rate. And then every 6 hours, there was like a 20% drop. So 7 to 12 hours was 79.3, or let's just say 80%. And then 13 to 18 hours was 60%. And 19 to 24 hours was 40%. And then 25 to 48 hours, the survival rate was about 24%. And then greater than 48 hours, it was 7.4%. Truth in advertising here is these survivals many times are not pretty. I mean, you have atrophy, You have calcifications when you look at these testicles with ultrasound. These many times are badly damaged testicles. But nevertheless, the survival rate is far, far greater than 6 hours. And that's the word that's just got to get out there is let's just stop. Let's just stop this messaging that's wrong. And that's, I think, frankly, it's resulting in dead testicles that could have survived.
The greatest tragedy of life.
Larry, let's talk a little bit about that pain. Sometimes patients don't experience pain the way we think they should. The textbook tells us this should be extremely painful and that the patient should present soon after that pain starts because it is so painful. But your research and publications tell us that the pain associated with testicular torsion is a little bit more complicated.
In multiple cases I have reviewed, the patient had a severe onset of pain, went to the emergency department, was misdiagnosed, and was sent home. The patient would just hang around at home, slept all night, and then a day or 3 later, started to have some worsening pain. They returned with this gait that I best describe as a saddle sore cowboy. And it just didn't make sense to call this a torsion, detorsion scenario. The testicle was dead. One of the things that I find very commonly is I have young men come to the pediatric ED who have dead testicles, and I'll say, does it hurt? No, it's not hurting. Only if you bump it or touch it does it hurt. So I had a series of these patients, and I wrote this paper called Testicular Torsion Pain Honeymoons. Essentially what that described is this event of absent pain. Why this happens, the afferent fibers for the scrotal contents run in the spermatic cord. As that spermatic cord twists, that nerve is also compromised in the process. They no longer are feeling sensation because that nerve has been compressed and compromised. Only when the inflammatory factors of the dying testicle starts to irritate the other areas of the scrotum, which are innervated by other nerves, do you actually start to suddenly feel pain again.
Finally, Larry, let's talk about how to actually detorse that testicle. And we are going to get into this new technique, the testicular torsion traction technique.
Ooh, that sounds fancy.
But before we get there, I got to ask, do we need a new technique for detorsion, or can we rely on what we've all been taught, the open book approach for detorsion?
Swami, we absolutely don't need to move away from the traditional detorsion technique. That works perfectly well when it works. I mean, manual detorsion of the torse testicle is usually simple and quick, and it can be easily performed by anyone. Unfortunately, there's a subset of torse testicles for which manual reductions are not simple, quick, or easy. Go ahead, try the standard open book technique. It works, but when it doesn't work, you need a backup. That's where the torse testicle traction technique comes in.
So our standard technique can still be used, but I think we kind of need a step-by-step approach. So you have the patient in front of you that you think that testicle is torsed. You've got ultrasound either at bedside or if you've gone with the patient to get that ultrasound done. Walk us through your process of reducing that testicle.
So what I do is I go ahead and start with the open book technique, the external rotation of either the right or left testicle. And if I run into a hard stop or I get resistance, then I try and go the other way. If pain's worsening and the patient's protesting and I get some resistance, that's when I move into the torse testicle traction technique. Essentially what you do is you grasp the testicle with one or both hands, and then you stretch it its maximum length.
Is this legal?
And you can observe whether the testicle spins or flips after that stretching procedure. As you stretched the testicle and the spermatic cord as far as you can, then you begin unraveling that testicle. And again, you're doing the external rotation, but if you find you're meeting resistance or seem to be making things worse, then you obviously have to go the opposite direction. Resistance of any kind generally means that your reduction maneuver was in the wrong direction. And then after that, you ultrasound the testicle to confirm a return of blood flow. What's interesting with this particular technique is that you actually will see a return of blood flow even before you do the detorsion procedure. This physiologically just makes so much sense. You're stretching that tightly wrapped spermatic cord, you're lengthening that helix or that area of twist, and consistently I have seen blood flow return, a modicum. It's not the best, until you actually then continue with your unraveling of the testicle.
So that traction technique, really, it's like those old phone cords. I know nobody has anymore because we've all got cordless and who's using a home phone anyway, but those old phone cords, they would always twist up. But if you pulled them, if you stretched them, they would just unravel on their own. And so what we're saying is that we're going to pull that helix of that twisted spermatocord to length, and then we can rotate to open that book a little bit more to really unravel the spermatocord completely. But just pulling to length can return some blood flow. It's not the definitive procedure, but Larry, we never think about our approach to detorsion in the ED as the definitive procedure. All of those patients need a urologic evaluation and to go to the operating room for orchoplexy or whatever else the urologist is going to do. So we know that we're not fixing the situation completely, but this just gives us another approach when our initial technique doesn't work. And I think that's what's really important here.
Hey, sorry to interrupt, but what the youngins may not realize is that phones used to do one thing, make phone calls. You couldn't take pictures, and they were connected to the wall with the long cord. Nowadays, they got the newfangled wireless phones. Wouldn't that be great? A wireless testicle? You'd never worry about torsion ever again. I'd love to be wireless.
Summary.
There are two dogmatic teachings that we need to eliminate from our brains. The first is that the testicle is gone if it's been over 6 hours of torsion. Your systematic review goes through this and really shows that even up to 24 hours, there is a significant number of testicles that are viable, and even out to 48 hours. There's still a lot of testicles that can still be salvaged. And so we can't give that cutoff of 6 hours and say, oh, it's been more than 6 hours, nothing to do here. And then also relying on the pain and understanding that that pain can come and go. The pain might not be there initially, or the pain at rest might not be there initially, but it's when that testicle is handled or there's any kind of contact with it that we get pain. So we can't always just rely on pain to give us this diagnosis. And then once we do make the diagnosis with ultrasound, we're going to use these techniques to unravel that cord. We can start with the open book technique. If that doesn't work, or if we're not seeing the same reduction or resumption of flow that we want, then we can add to that testicular traction, pull that cord to length, and then unravel.
I hope that having this additional technique, there'll be an explosion of confidence in emergency providers to actually try manual detorsion.
So long, everybody. Remember, we're survivors. Don't count us out. Every testicle deserves a chance.